Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Light go through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about... Okay. Yeah, okay, relax.
Welcome to my YouTube channel.
Hi, it's Dr. William, and welcome to our live tonight. It's like every live, there's more stuff to talk about than there is time, but I'm going to do the best we can to get through as much as I can. Tonight we're going to be focusing on breast surgery and primarily breast implants. And I have a whole list of things I want to talk about. Well, it's a huge topic, but I'm going to try to get through as much as I can. And we could end up talking about fat grafting to the breast. We could end up talking about tuberous breast, breast lifting, breast reductions, implant removal. There's a whole bunch of things to get into. I'm also going to take questions. So if you have some questions, you can leave them in the comments. And I'll break out and then we'll just take some questions for a while as well. I would prefer if you could keep your questions on breast so that we stay on topic. Okay, well, let me dive right in. And just like when I was in medical school, the first thing we learn is anatomy. And there's a lot of confusion with where people think the implant should go, where they can go, where they do go. And so I want to kind of start there and clear all of that up by going over some anatomy. And I'm very fortunate enough to work with some outstanding people that have really made a lot of this tonight possible, because I have a lot of props and a lot of things to use to explain things to you, so that you can understand the anatomy, because it can get a little bit confusing when people are talking about over the muscle, above, under the muscle, where are we putting an implant. So that's the first place I want to start. We're going to talk about the anatomy of the breast, and then we're going to go through and I'm going to show you the locations where you can put an implant in the breast to enhance the breast with the breast augmentation. Most people think over the muscle, under the muscle. There's actually 4 places where the implant can be placed on the chest. They all have benefits. They all have detractions. But I'm going to go through, and so we're all on the same page as to where an implant can go in the chest. And for that, I wish I could say I made this, but I did not. This was made by my team, and it's really excellent. And it's one of the advantages of working with a good team, because they understand already the anatomy. We've worked together for years now, so we've both learned from each other, and we've learned a lot of things. So what this is a model of a breast, and then it opens up, and then now I can actually show you what the layers are and where an implant can go. So let's just start from the very beginning. Obviously, we're talking about the mammary gland. That's the breast, and it's covered in skin. There's a nipple and the areola on top. And then if we kind of look, okay, well, what's underneath the skin? So if we go, is this the best way to do this, or you want me to do this here? Okay. So the best way to do it is we're just going to dive into it and look. So if we were able to just remove the skin, and there's a small amount of fat that goes under the skin, like everywhere in your body. And if we then look inside the breast, okay, let's see what's going on here. So this itself is the breast right here. The breast is composed of breast tissue and fat, and they're kind of intermingled, but primarily the gland is a little bit more central located, which is these are these little ducts here. If lactating and you're producing milk, then these will produce the milk. They go through the ducts, and they go out through the opening in the nipple. So the breast gland is covered itself by what we call a lamella, which lamella is the best way to think of that is kind of like an envelope. So the breast is covered in this what we call breast lamella, and we're going to get into more as to why I'm showing you this. It's usually adherent. It's not sort of free floating like this, but it's more adherent, kind of like the lunch lady with the hairnet. It's kind of stuck to it. So this is the breast gland. Then underneath the breast, I'm gonna skip a couple layers, and then we're gonna go down, and these are the ribs, and this is your sternum. So the sternum is the middle part. That's also called your breastbone. That's the sternum. That's represented here, and then these are the ribs. And in between our ribs, we have this muscle, which is intercostal muscle, and that helps with respiration. And then if we were able to go deeper, right there are our lungs and heart. So if you were to actually go through this little muscle, the intercostal muscles between the ribs, and were to poke through there, you would go right into the lung, or on the left side, central part, you go into the heart. So if we start at the ribs, that's your chest wall. There's a lot of different types of chest walls. There's patients that will have a flatter chest wall. There are patients that will have a chest wall that kind of comes in a little bit. There's going to be patients that have a chest wall that comes out a little bit. And then there's all different types of slope to the chest wall as well. And that can play into how your implants sit long term, whether they're going to be going down to the sides or not. Part of that is related to the shape of the chest wall. For women that have very flat chests with centrally located breasts, then we put implants in. They tend to have good longevity to their implants. Patients that tend to have more of a pigeon-shaped chest or more of an arc chest, they're going to have more traction on those implants following gravity sort of down and out. So that's the chest wall. What sits on top of the chest wall is your pectoralis major muscle. So whenever anyone says above the muscle, below the muscle, any of those things, they're talking about this layer here, which is a pectoralis major muscle. There is a small pec minor muscle that lies under here, but it's not really clinically important for any breast surgery. So here's the pectoralis major muscle. That's a major landmark. That's the main muscle in your chest. And that, I'll just show you, draw that for you. If we look here, if here's your sternum, your collar, your chest breastbone, and then you have these ribs that are coming out here, like we've illustrated here, then those are your intercostal muscles. And then the pectoralis major muscle, the big muscle, so when you're doing bench press or any major pushing activity of your upper body, it involves the pectoralis major muscle. And that muscle attaches, if we show where the clavicle is, so your clavicle, the clavicle bone here, the pec muscle itself will attach along there. It attaches to the chest. It kind of blends in with muscles from your abdomen as they're coming up, the rectus muscles. So it comes across here, and then it kind of goes more like this, and then it sort of tails out. And when it gets to this tail, this part here, it's actually connecting to your arm bone, to the humerus. So if you look at your arm and you have your armpit, well, the front border, what makes up the armpit, the front border, is this muscle. And that's the pectoralis major muscle, and that's this part over here. And so that attaches to your arm. And that composes the main muscle of your chest. That's what's represented here. That's the pectoralis major muscle. That's the main muscle. So a lot of times when we're talking about implant location, we're talking about things in relation to the muscle, but it's a little bit more complicated than that. So that's why I sort of have this model that they made for me. So then there's another layer, and this is a layer of what we call fascia. And this fascia is closely associated with the pectoralis major muscle. Pectoralis major muscle is thicker than this. But the fascia, it envelops the pectoralis major muscle. And that is a common theme throughout our body, is that muscle is, just imagine that you have the best way, and this may turn you off from eating flank steak, but the best way to kind of think of this pectoralis major muscle is like a flank steak. It has the same striations, it looks the same. But if you look, and sometimes when you're watching cooking videos or something, they'll talk about taking off the silver skin. That's usually what they're talking about. And when they're talking about that, they're talking about the fascia. So fascia envelops the muscle. Muscle in and of itself is not particularly strong. But when the body has fascia on it, which it does with muscle, that becomes really the strength. So that sits here, and then your breast gland itself sits on top of the pectoralis major muscle fascia. And then the breast gland itself is covered by this hairnet, this lamella. So just to kind of review, you have your skin. If we go inside the skin, then you're going to see your gland. The gland is itself wrapped in this lamella. Very similar concept to this fascia here, where it's covering the muscle. So this lamella covers the breast. Underneath that, you have your pec muscle with its overlying attached fascia. And then underneath the pec muscle, we're now down to your ribs. So I'll just use this model and an implant that I have here to show you the 4 different locations where an implant can go. So the first, and this has changed over time as to where implants used to go, and it's also changed with the technology of the implants, allowing us to put the implants in a little bit different positions. So if we go back, way back in time in the late 60s, when they were starting breast augmentation, they would take the implant, and if you're going to do a breast augmentation, you're going to make the breast bigger, more cleavage, more fullness, bigger size, then it only made sense, well, you're going to put the implant right underneath the breast gland, and then the result of that is you're going to have a bigger, fuller breast. Those are implants. Those were Dow Corning implants decades ago, and they were first generation. They had problems with leakage and other things, and rippling, and seeing the implant, capsular contracture, which we'll get into some of these things. And so there were a lot of problems associated with them, and so somebody came up with the idea, well, instead of putting it underneath the gland, why don't we put the implant underneath the muscle, underneath the pectoralis major muscle? Okay, so now we can get an augmentation of the breast by putting the implant, instead of right under the breast, we can put it under the muscle. And that we saw a lot of benefits to doing that. And when I learned to do a breast augmentation in the early 2000s, about 20 years ago, let's say, that's what we did all the time, because that had a lower rate of capsular contracture, which is hardening the breast. We'll talk about that after. And it also allowed this muscle here to cover and conceal the implant a little bit better, so we didn't see as much rippling, and we didn't see the implant as well defined, like, oh, there's just a round rock on your chest. And so we used that for many years. And then really what we learned through breast reconstruction for patients that have had mastectomies, and with improvement in the technology of the implants, it became a better idea, or at least a possible idea, to place the implant right under the gland. And so in breast cancer, you've had a mastectomy, there's no gland, but they were putting it above the muscle. So a lot of that was afforded because of the newer technology of the implants. And if you really think about it, the best place to put an implant that makes most sense, you're not accustomed to having something under your muscle to give you a better looking breast, but it makes sense to put it under the breast. So a lot of times when I see patients, they'll be like, it's going to go under the muscle, right? And quite often I still do put it under the muscle, but not always. And if somebody has some tissue and enough gland that we can put the implant underneath the gland, you get a really nice result. It's an easier recovery, and there's a very minimal amount of increase in complications from putting it there. So it's safe to go there. And it makes intuitive sense. And then as time has gone on, it became more than just above the muscle or below the muscle. And so the next step was, can we create a space that's kind of the best of both worlds? It can be not right under the gland, but it's not right under the muscle. And so what is that space? So that's the space that I use quite frequently, and it's called the subfascial plane. So that opened up a third option for us. So the first option was originally going underneath the gland. The second option was going underneath the muscle. And then because we've had a lot of experience with breast reconstruction and mastectomies and everything else, we realized, well, we can actually place the implant on top of the muscle, but it's not right underneath the gland. It's actually underneath the fascia. So we call this a subfascial augmentation. And I usually don't split hairs with patient and go into this detail. I usually just say the implant will, when we decide, it'll be under the muscle or it'll be under the gland. But really when I do it and I'm putting it under the gland, I'm actually putting it in this subfascial space. And what does that do? That gives us a nice little protection of the implant from the breast gland. Because if you think about it, the breast is open to the air. Now that doesn't mean you're opening to the nipples or wide open and you got air coming through, but there is still a communication and a pathway. And so we think, well, if we can keep the implant away from the gland, we can have a little bit less risk of having any bacteria that's in the gland because it's open to the air, getting in touch, communication with the implant, and we think that gives us a lower rate of capsular contracture. We know it does. Now, when you think about all of these types of things for risks and benefits, and we're not talking like, oh, if you go under the muscle, you're never going to get a capsule, and if you go under the gland, for sure you're going to get a capsular contracture. It doesn't work exactly like that. It's small little changes in risk. So this is a nice place to put an implant. I do this quite often, or I'll put it under the muscle. Those are the two most frequent places that I'll place an implant. There are times when I'm going to go and I say, well, I'm going to put it under the fascia, and patients don't have as much development of the fascia. And it doesn't happen that often, but I'm unable to kind of create this plane between the fascia and the muscle. And in that case, I will place it in the subglandular position where the implant is right underneath the gland itself. Or really, it is, but it's got a little lamella, that little envelope, that little covering that's there. Now, there is a new fourth space that we can use, and that is in a sublamellar place. Okay, so what does that mean? Well, it's kind of hard to show, but I'm going to do my best here. So what that is, instead of placing the implant right under the gland, instead of placing the implant underneath the muscle, what we're doing, and this is the new Preservé technique that's been developed by Motiva, is they're creating a space, and I'm going to go over the Preservé system here in a minute, but it's allowing the gland to, or the implant itself to be in this spot. So that's a new fourth location, at least the way I consider it, a new spot for the implant to go. And the advantages of that is that there's more preservation of the surrounding ligaments. The breast itself is not just floating on top of the chest wall. It's not just floating on top of the fascia, but there are ligaments that are connected between the breast itself and the chest. And with the preservé system, which is why they call it preservé, is because it's preserving tissue. And what tissue is it preserving? It's really preserving those ligaments. And so by sneaking into this little space here, you can leave a lot of these ligaments in place and just place the implant. Whereas when we do a breast augmentation, in order to create the pocket, we do have to go through some of those ligaments. And that's not preserving as much tissue, and you can think of it as weakening the breast. Now, none of these things are cut and dry. You could have 10 surgeons and they could talk about why each space is better and why they think it's better and why they think that's what the best option. I'm not really dogmatic like that. So I do it more of an individual patient to really examine the patient, talk to the patient, look at the patient, and decide what would be the best location for that implant. And I'll give you a couple scenarios. So if you have somebody who has really not a lot of breast tissue, so if they don't have this sort of mound of tissue and they don't have any skin, and this is just perfectly flat, then if we were to place the implant right here, we're going to see that implant. That's going to be very visible. You're going to see more round, not roundness, you're going to see the edges of the implant more. So for someone like that, where they just have really very little breast tissue, not a lot of fat, then in those cases, in my opinion, it's still better to put the implant underneath the muscle, because by putting the implant underneath the muscle, then what we do is we are providing some coverage of that implant to hide the implant. So you don't see as much of the implant itself in somebody who really doesn't have much breast tissue and doesn't have a lot of fat. If we just put it under the gland, you're going to just see that implant, and it'll be a very unnatural look. So that's an example of where I would say, okay, well, let's go under the muscle. We'll use the muscle and the overlying fascia to be able to conceal the implant. For patients that have more breast tissue, but they may have some hollowness in the top part of their breast, they may not have very much cleavage, but they do have some breast tissue, and they do have enough fat underneath their skin in this area, then we can place the implant either subglandular or we can place it in the subfascial. That's my preference, is to go subfascial. And if I don't have to lift up the muscle, or I'll explain in a minute, we have to actually cut the muscle. If I don't have to do that, I think in my mind it's better, because we're still in a very nice place, and we conceal the implant. You don't see it. It's a more natural appearance. Then I prefer to do that. So those are kind of the two scenarios. Now, I'll take you through how I do a breast augmentation. We all do it similar, but there are some little differences. I'm older and I do it the way I was trained. I've kind of gone full circle to how I kind of do breast augmentation over the years, but I really go back now to my roots, and I'll show you how I do it. So let's say, just for sake of argument, I'm going through and I'm going to put it in the subfascial plane, so that's in between the pec muscle and this fascial layer, and that's where the implant is going to go. Well, what I will do is I make an incision underneath the breast, and then I'll find this fascia. I'll start developing the pocket, and we'll lift this up. And then what I do is I use what's called a sizer. And this is this is a sizer. And I can then place that sizer into the pocket that I've created, and I carefully create it so that it's going to have, when you do this, then you kind of know what the pocket should look like. And so I create the pocket, and then I'll use the sizer to do two things. Number one, it'll confirm when I inflate this, it'll confirm that the pocket that I've created is correct and it looks good. So what I'll do, and I'll just leave this here so you can see, but what I'll do is I will inflate this, and it's fairly easy and it's fairly quick to inflate it, and I just use air, and this starts to inflate this. So now we're at 150, now we're at 200, now we're at 250, now we're at 300, and this is a 320 sizer. So that'll allow me, because remember, when we're doing this operation, we don't have everything open like this. We're working through a small incision underneath the breast, and we've got lighted retractors where we can see and things. So, but then what we'll do is we'll look at the breast, and we'll say, okay, how does that look? How does that size look? How does the cleavage look? How does the shape look? Is the pocket look like on the outside like I thought it would when I created it on the inside? Most of the time it does. Sometimes I have to tweak the pocket a little bit. And then what I'll do is inflate that sizer, and it gives me a little bit of play. So I will always want to have like a hand and glove fit. So I want the implant to fit in snugly and perfectly within the pocket. And so I can confirm that the breast looks good, that the pocket looks good. Okay, then what do? And I can play with the size a little bit here to kind of see how the breast looks. For me personally, everything is about shape. I want the patient to leave the operating room and they have a good shape. To me, I don't really care what the number on the bottom of the implant says. I care about what the shape looks like. So if this is a 300, if I've blown this up to 300 and that looks the best, that fits the breast, it matches the chest, it matches the patient's body, then I'll put a 300 in. If I've inflated this to 375 or 450 or whatever the number is, then I'll simply take out the sizer and I'll put the implant in of that size. And that way I can kind of see how the breast looks, make sure the shape is good, make sure the pocket is good, make sure there's a good fit between the implant and the pocket, and then I put the implant in. So it's a little bit, I think, older way of doing things. For me, it works really well. I can get good, consistent results. I really can't even remember the last time that I had to change an implant size. Somebody thought it was too big or too small. It usually works really well because we create the pocket, we match the implant to the pocket. So I'm really matching the implant to the breast. Does this create problems when I do a consultation and people say, well, I want to have this size implant because my friend or my mom or I saw another surgeon, they recommended this size, and I don't give them an answer like, yes, I'm going to put in a 375cc implant. And that can make people feel uncomfortable, and I recognize that. But I still think it's the best way to do it. And what I tell patients is, if I was a shoe salesman and you came in to see me and you said, all right, I'm looking for a pair of shoes and whatever, I'd say, okay, stand up and stand on this 1940 gray little shoe foot measurer. And then we would measure your foot, and then I'd go back there, come out with all those boxes, and be like, okay, this is your size, these are the styles, which, let's try one on, make sure it fits, and then that would be the size. So somebody wouldn't come in with a size 7 foot and then say, well, I want a size 9 shoe. Well, that's not going to fit. I want a size 5 shoe. That's not going to fit. Your foot fits a size 7. I think, in my mind, the breast works exactly the same way. There is, in my mind, an exact implant number that will match the breast perfectly and will match your body. So it's not too small, it's not too big, it just kind of fits perfectly. So I don't get hung up on the number. I can give patients a range. Obviously, with experience, I know generally what someone will be within a range. And then we kind of discuss, and sometimes I'll look at photos. Do you want to be larger? Do you want to be a little bit smaller? There's some movement. We have some play within this pocket. I can't go from a 300 to a 400, but I can make, probably within 50 cc's if somebody says, well, I want to be as big as I can, and I put this in and it turns out it's 375, I can play with a little bit, and I might be able to go to 425, 450, something like that. And then that's how I determine my implant. And I know I'm a little bit different in terms of doing that, but it's an older technique, and it's the way I originally learned. I changed to a lot of different techniques over the years, and probably within the last, 10 years, I've just come back to the original way that I was taught to do it, because I think it makes a lot of sense to me. And like I said, I think I can get a good, consistent result with minimal complications. So I use a sizer. Now, the very funny thing is, and I'm going to talk about all the different implants too, but the very funny thing is to me is that here I am, picture me, Duke, circa 2004, using this, and now here we are coming out, I'm not exactly sure when, probably within a month or two. Now we have a new way of doing it, which is the Preservé technique, but lo and behold, guess what they use? They also use a sizer of sorts, and so it's kind of funny to me. But I'll take you through the Preservé now and show you how that works. It's really a cool operation. I think it definitely will have a place in breast augmentation. I don't think everyone will be converted to Preservé, but I think there will be good candidates that are good candidates for Preservé. So let me show you how that works. So it's a really nice technique. It's a clever technique, but it does tickle me how we're using this since a long time ago. So what happens is, with the Preservé technique, it's a different procedure because it's a blind procedure. And what I mean by that is we're doing a lot of things based on our tactile feel, and I imagine that I'll be using ultrasound, and I've seen surgeons who've used ultrasound, and I think it's nice confirmation as to exactly where you are, so you're not totally blind. But how this technique works is, I'm going to have to open up the breast to show you, but there's a small incision, and it's smaller than the incision that I would make in order to place the implant, say, under your muscle, for example, or under the subfascial space, or even if we went subglandular. I need a little bit bigger incision because I need to see what I'm doing. And in order to do that, if you make the incision too small and you're trying to look through, you lose your binocular vision. And so then you end up doing sort of a one-eye thing, and you don't have good depth perception. So you need to make the incision big enough where we can see and work. With this technique, it's a smaller incision, because this is actually what is creating the pocket. This is what we call a trocar. And it's sharp here. It's not something where I'm going to cut my hand when I do this, but it is sharp enough that it can tunnel. And so the first step of doing the Preservé is to fill or infiltrate the breast with something similar to what we use for liposuction, which has some numbing medicine, and that will help to distend some of the breast tissue, and it provides anesthetic to the patient, and it also has a vasoconstrictor, epinephrine, or also known as adrenaline, that will decrease the chance of bleeding. And so what happens with the Preservé system is, and I'll kind of have to just work with this here a little bit, but if you look what's happening, if you could see this, is this trocar will go through the skin in a small incision, and then what happens is trocar enters, but instead of, we're not going under the muscle with it, we're not going under the fascia with it, we're not going under the breast with it, we're actually going into this new little space within this breast lamella, okay, which is, again, it's more adherent here. But what happens then is we'll take this trocar through the skin, but what's happening on the inside is we're going to make a tunnel. And so that tunnel will be underneath the breast lamella, this covering of the breast gland. And so that will go underneath there, and it's usually sort of angled a little bit here. And then what happens, so really nothing is really being cut. What's happening with the preservation system are things are being displaced. So they're able to preserve the surrounding ligaments of the breast and just sneaking in here underneath the breast lamella. Once that channel, once that pocket has been initiated, then the second step is to use this state-of-the-art device where this will then follow, and this is smaller and collapse, and this will then go into the same path that the trocar had created. This will go into the same path, and then it'll be in this little lamellar space. So let me just kind of put that in here. And so that'll be in the lamellar space, and then it has a bulb on it, and it gets blown up, and then that starts to develop the pocket where the implant will eventually go. And that distension will really just displace the breast tissue. So whatever's breast tissue's there kind of gets moved to the side, so it gets moved to the middle of the breast, so you can get more cleavage with your own natural breast tissue, and you get more fullness and roundness on the side with your own breast tissue. And then, because of their implant technology, they have a different implant. They actually have a lot of implants. The implants that we have available in the United States are only 2 of their implants, but they're working on, I think, even their 6th type of implant. But their gel and their shell allows this to be, it's really pretty cool, withdrawn into this device. And then that device is placed after we've done this, then that new device will go, and it kind of can make the implant smaller to fit through that little tunnel, and then it'll deploy that implant. I mean, it's really kind of cool. It's like, and then it's like, and it inserts it. So the implants typically used for preservé are smaller, and they have some really cool, like diamond-shaped ones and things like that, that can then be put into that device and then inserted into the breast. And because we're kind of utilizing the breast tissue to be able to keep the cleavage and the fullness, the implants are typically smaller. And so they're smaller incision, smaller implants. That doesn't mean you're going to look smaller, because we're kind of moving your tissue. It can still give you the same kind of look as if we were using a traditional implant. So that's a preservé system. It's pretty cool. I'm sure you've probably heard a lot about it already, but I can imagine in the next month or two you'll be hearing a lot about it and seeing a lot of people using that. So it's exciting. I think that it's a nice technique. Like I said, I don't think it's going to replace everything to do with breast augmentation, but I think it's definitely going to have its spot for patients. From what I've seen, the recovery seems like it's faster. Patients are up moving quickly, and so I think that's definitely going to play a role. And I'll talk about it, and I'll show it in the operating room and all those things in a couple of months. So that's in a nutshell where the implant is. I'm going to show you one more way to explain it to you. And so here is another example. So if we look on the outside, okay, you see that okay? Mm-hmm. So here's the breast, here's the nipple, the areola, here's the breast, this is the chest wall. But now if we look inside, okay, here's the nipple, the areola is here. And now we look inside, okay, what is going on? And it's exactly what I just showed you with the other model, but this is just a different way to sort of explain it. So if we look at this cross section here, and this is just a regular breast, there's no implant. So what do we have? We have skin, We've got fat that's under the skin. You have lymphatics, that's the green. And this pink here is the breast. These are the ducts that are going out to the nipple. And then underneath that, you have the pectoralis major muscle. And then you have your ribs. And then these will be your lungs. So here's your chest wall. There's your ribs. This is the pectoralis major muscle. This white is the pectoralis major muscle fascia. So when I was talking about, let me just do this so you can kind of really see. When we're talking about this, so if we just kind of use two of them together, here are the ribs. There are the ribs. This is the pectoralis major muscle. That's pectoralis major muscle. Here's the fascia on top of the pectoralis.
Could you lay the other one down so that you could kind of, for the overhead camera, you can see both of them?
Oh, yeah, sure.
Yeah, exactly.
Okay. So let me just start again. These are the ribs. These are the ribs. This is your pectoralis major muscle with the overlying fascia. There's your pectoralis major muscle with the overlying fascia. And then here's your gland. Here's your gland. And then this is the skin and fat. And there's the skin and fat. So that's just the regular breast anatomy. Now, let's look at the different locations that we talked about. So we're talking about this, is it better this way?
No, for now, yeah.
Okay, so this, ribs, muscle, fascia, this is fat, lymph nodes, here's your gland. This is an implant. This would be in a subglandular plane because here's the implant and there's the gland, it's right subglandular. The next place to look is in the subfascial plane. So here's your gland, here's the implant, and you'll notice that instead of the fascia being in communication with the pec major, now that fascia has been lifted up. So you get that little white line there. So that's a subfascial placement. Then, here we are here. And this is the submuscular location. So now the muscle, the pectoralis major muscle, has been lifted up and the implant has been put behind the pectoralis major muscle, behind its fascia, and separated from the implant from the gland by the pectoralis major muscle. And then, do we have the lamellar one?
No.
No, okay. So then for the lamellar one that I just showed you with the preservé, it would be the implant, instead of being behind this pec fascia, the implant would be underneath the breast lamella, or above the breast lamella underneath the breast. So those are implant locations. That's where we can put it. Typically, we'll use an incision that goes underneath the breast. So if we're looking here at a breast, and here's the areola and the nipple, then the incision is typically, in this area. That's what we call an IMF incision, or an inframammary crease. That's the crease that's under your breast. It is the best place to make a breast incision. Sometimes patients, just because I'm in Miami and a lot of times in South America, the implant is placed through what's called a peri-areolar incision. The problem with that is when you make the incision, let's see, where's the normal one here? So when you make the incision here around the areola, and you want to go all the way down here and put it under the muscle or under the fascia or even under the gland, you still have to go through some breast tissue. So we prefer not to, and there's a lower rate of infection, there's a lower rate of capsular contracture if we go underneath the breast. So the best incision is really under here. And it's a hidden incision. Sometimes patients are like, well, I don't want to see my incision. Well, you won't see your incision because the incision is hidden in that fold. It also allows us to do something which I do for all of my cases, and that is it allows us to, because we've disrupted that part of the fold when we've gone in, it allows us then to put sutures here to recreate the fold. And that way, when you look at the breast, you get a nice, sharp, crisp angle here if I can set that fold. And so it gives you a sharp, crisp angle here. You're not blunted, which sometimes patients that I've had where patients have had a blunted angle like that, they don't necessarily complain about it or mention that it's a problem, but I still prefer to have a nice crisp line here. The other thing it does is it helps to secure that fold so that if there's any pressure from the implant on that fold, it's not weak from my opening it up. It's nice and solid and it's tight, and it's not possible. It limits the amount that an implant will bottom out. It's not that it's not possible, but it limits it, and it gives that nice crisp fold. So that's another advantage of going into the inframammary fold location for the incision. So this one, I really don't do this peri-areolar incision. Different situations I do it, but that's when we're talking about lifting or tuberous breasts or something. But by and large, this is the best incision, and that's the incision that I use. And even when, excuse me, even when you use the preservé, still making an incision in that inframammary location. Okay, that's where the implant goes. That's how we get the implant there with the incision. And let's say, okay, well, what type of implant are we going to put in? In the United States, there are 4 options for implants. There's 4 main manufacturers, and I use 2 of them. I use either a Sientra implant or I use a Motiva implant. And the Motiva implants are a newer technology. I put many of these implants in, the Sientra implants. They're fantastic. They work really well. There are some advantages. You get a little bit thicker capsule, still soft, but you get a little bit thicker capsule, and that I think is also a little bit more supportive of the chest. And so I kind of will vary this from patient to patient as to which one I think is better. But they're both excellent implants. They're both what we call smooth round implants. So it's a round implant. Remember, patients used to always ask for, a long time ago, a teardrop implant, which had more of a quote-unquote natural shape to it, where, can you see this here? Yeah. So where the implant was more of this kind of shape. It had a what we call polarity to it. It had a front and it had a back. And the problem is, if you put something into the chest and it has a front and a back, it doesn't look very good if the front is facing backwards, if the implant flips. And so what they did is they texturized, instead of having this smooth, they put different texture in here. And that has been associated with a certain type of breast cancer. That's not common, but it's from textured implants. So we no longer use textured implants because of that risk. And so that's why we don't use teardrop implants, because if you don't have it textured and it's smooth, it can rotate, and then you have to go in and change it back and some other things. So, but nowadays all the implants are smooth. Now, why is this one blue and this one is not blue? Well, it's in the manufacturing process. They put a different layer. The shells are made up of multiple layers, and they will put in at their first layer a layer that has some blue dye to it. So you can see on inspecting the implant, and they can see this in the factory, to make sure there's no problems with the binding of that layer of the shell to the gel that's inside. And they can tell that it's well bound, because if it's not, you can see because of the blue color that there'd be a little area. So it's kind of a safety feature that they have and a quality control, and I think it makes sense. The other thing you may or may not appreciate on the video is that this implant is truly smooth. Like, this is absolutely smooth, like a baby's butt. This one is not as smooth, but it doesn't really feel textured. So we technically don't call this a textured implant. We don't even really call this a micro-textured implant. This is a very, 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 very thin, if you were to look with a microscope, you'll see that this surface here would be smooth. But this surface, if we were able to look with a high intensity scanning electron microscope, for example, that this surface would actually look more like this. Now, when I feel it, does it feel like that? No. This one feels just like that. But you do get a sense that there's something there. But this is small. This is only 4 microns. The whole height of this coating that they have. And the reason why they have that is they did some studies with a pretty well-known scientist, and they published in a very prestigious journal, talking about how just a small amount of this irregularity in the shell can reduce the rate of capsular contracture. And we'll talk about capsular contracture in a while, but that is one of the advantages of this implant and of having this type of shells. There's a little lower rate of capsular contracture with it. But that's why it's blue, that's why it feels a little bit different. This is a state-of-the-art gel that they have here. This is a proprietary gel that they've altered. I don't really know exactly, but it does have a little different feel to it than this implant. It's a little different how the silicone molecules are kind of bound to each other. So those are the 2 different implants that I use, either Sientra or Motiva. Patients are asking for Motiva implants because this has only been available in the United States for about 1.5 years, a little bit less even. And so there's a little bit more the new, I want the Motiva implant, and I think they're phenomenal implants. I think both of these are excellent implants, and so I will kind of tailor that to the patient as to where we're going to go. There's a lot more to know about implants than just that there are 2 different manufacturers. There's 4, but there's 2 that I use. There's a lot of other things to talk about with implants, but essentially they're all silicone, they're all round, and we consider them all to be smooth. There are differences in the way the implant is shaped. This implant, if you'll look at it, it just looks a little bit different in that this kind of has a little bit of a beveled edge, if you will, and more of the implant here. This one sort of comes straight up from the chest wall. Each manufacturer will have different claims to the benefits of either one. I'm not really able to say, well, this is better or that is better. Both of them yield really pretty beautiful results. And both of them feel really soft and really natural and really produce a nice breast result after an augmentation. One of the things I'll talk about is the profile, and that comes up quite frequently. You want a high profile, I want a low profile, medium profile, moderate profile, and everyone calls their different profiles different names. There's demis and fulls and moderate plus, and there's a whole bunch of things there. You don't really need to know all of that. You should understand, though, the concept of what a profile really means. So the best way I can explain that is just by drawing this little ladder here. And let me just change this sheet out. I don't want to lose my list, but okay, so the best way, I think the easiest way to understand it is from understanding the profile. So here we're talking about profile, implant profile. The best way to really understand it is to kind of consider it this way. So if you consider implants that are all the same width, okay? They're the same width. This, what I mean by width is this. This is the disadvantage of having a beard, as I get my beard's falling all over this implant. Okay, so here we have a certain width of the implant. This implant has a certain width to it. If we look at consistent width for each implant style, then what you really see is then you see the difference in the profile. And so for the same width, you'll have an implant that could be like this, and that would be a low profile. And then you can have an implant that same width, but you get a little bit more in this direction. This is really the profile now we're talking about, because this could be like a moderate profile. Then you could have an implant of the same width, but now you get more projection. So it's projection in this way. I think a lot of confusion comes where people think, well, I don't want to have these breasts up here, and I don't want a high profile because I don't want a breast up here. That's not really how the profile works. The profile is working in this dimension, in this direction. You do get a little bit more fullness in the upper part of the breast when you use a high profile implant, but that doesn't mean you're going to have the implant going into this spot where where an implant doesn't belong. We want the implant centered under the breast. So profile is really in this direction, not in this direction. And so then this implant here with more projection based on the same amount of width, this will project more. You would call this a high profile implant. There are other implants that are more projecting, and those are like an extra high, or there's a bunch of different names. That will have the most projection. That will have the most projection in this direction. The most projection. I personally live in these areas, here and here. I personally don't like the appearance of a breast augmentation with a lower profile implant. To me, the breast looks more flat and more not as appealing. There are a whole group of patients that like that look, and there are a bunch of surgeons that also like that look, and those patients will usually find that surgeon that does a lower profile. I personally don't like the way it looks, so I don't use low profile. I don't have them in my office. I also don't use the extra high profile implants, which have that maximal projection, because these implants were really developed for reconstruction. So patients who had breast cancer and they've lost their breast with a mastectomy, then they don't have any breast tissue. They don't have any breast here. So we're recreating their entire breast from an implant. And doing that, you need the maximum amount of projection because they don't have anything. And the interesting thing, because I used to do a lot of breast reconstruction for about 9 years, and the interesting thing is sometimes I would see a patient in consultation prior to, so they'll see the oncologist and maybe radiation oncologist, and they'll see their breast surgeon, the breast cancer surgeon who's planning to do the mastectomy. And so in a perfect world, those patients will then also see the plastic surgeon before that so they can have some reconstructive plan in place. And then the plastic surgeon works with the breast surgeon, works with the oncologist, works with the radiation oncologist, and we all kind of come together up with a plan for reconstruction for that patient, when, how, all these things. And sometimes I would have patients and they would say, well, Dr. So-and-so sent me to see you for breast reconstruction, but I don't really want breast reconstruction. I just want to get rid of my cancer, and I'm not worried about having breasts. And I think what happens in the patient's mind is they would think, okay, well, I'll just be flat. I don't need breasts. I just want to get rid of my cancer. I'm just going to be flat. I'm not going to have any breast reconstruction. The problem is what patients couldn't foresee is they really weren't just flat. They were actually indented. And again, it sort of depends on the chest wall, but some patients would have quite large indentations if they didn't have reconstruction. But it just illustrates the point that without a breast there, you need the maximal projection. So that's really where this extra projecting implants came from, and they look great in patients for reconstruction, but they don't work really well, in my opinion, in cosmetic patients because I think they have too much projection. They kind of look a little bit odd to me. So I principally work in this category. I do more high profile. You kind of get patients who, if I like the shape of that and that's what I'm leaning to, then you sort of get patients that want that look. And where I live and what I like and what patients that come to see me like is they tend to like more of a higher profile. So I tend to live within this high moderate area, and to me that creates a pretty breast. There's other factors that go into it and can get a little bit complicated. I'm going to kind of ignore that because I want you to get the concept of this profile and not think in your mind, oh, if I get a high profile implant, I'm going to have this big spot up here. The patients that get those really almost rectangular or oval looking breasts with too much tissue up here, it's really not from the profile, it's because their implants are too big and so they can't fit under the breast. The implant is too big for their breast. So what does the implant do? It just steals tissue from the upper part and you can get that oblong shape. And I that's why I think with my old handy dandy sizer that I use, I can avoid that problem. Okay, so why don't we, God, I've talked for an hour and seems like I haven't covered anything. Let me take some, is it a good time for questions?
Yes.
Okay, let me take some questions here and we'll, necesito, judo. Okay. Oh my God. What year is this iPad? This weighs about 100 pounds. Okay. I'm just going to go through and answer some of these questions. Okay. Jennifer's asking if somebody has a saggy breast, they usually need a breast reduction, or are they good candidates for implants to get a more upright and firm breast? Okay. I could spend an entire I can expend an entire live talking about that. We'll get into it, but the general rule is if you're somebody who, well, let me just explain it to you this way. Okay, so if we're talking about lifting the breast, why are we talking about lifting the breast? Under what circumstance would you need a breast lift? I think most people can look at breasts and be like, oh, she has sagness, is droopiness, and she would need a lift. But how does it really work? Well, if we look at a breast with no droop, imagine this is a breast, there's no droop, nipples at the appropriate position, which is projecting. The nipple is at the location where there's the maximal projection from the chest wall. The nipple is located there. Here's your inframammary fold. That's what this line represents. And the whole breast and everything is above the inframammary fold. Okay? Those patients, straight breast augmentation. Put an implant in, they're going to look great. Over time, with breasts or breastfeeding or weight loss or whatever, what you can have is you can then develop droop. And there's different amounts of droop. And so this, instead of being nicely here, you can have this where the nipple starts to look down. You can have it where it starts to really come down more, or you can have the breast where the nipple is basically pointing towards the ground. These are different levels of droop. The more droop you have, the bigger incision it will be needed to be able to get your breast back up. Whenever we're lifting the breast back up because patient has droop, we're talking about doing a lift, a breast lift. It's different incisions for a breast lift. You can have a very minor amount of droop here and your nipple's not very low. We just need to bring it up a little bit. In that case, we can make an incision around the areola and we can lift the areola and lift the breast a little bit by using that incision. That's for pretty minor levels of droop. As you start coming down into this area here, then you're going to get more incision pattern. So if we can imagine, okay, that person gets just what we call a concentric, meaning it's just around the areola. That's for very minor amounts of droop. When we start getting into more droop, so we start getting into this person or this person, now we're going to employ a different scar pattern on the breast to get the result what we want, to lift the breast. And that incision is going to go around here, and the ultimate scar is like this. That's the so-called lollipop. Lollipop is not a particularly, it's regained popularity. People are asking for it now, and they had stopped asking for probably about 5 years or so, but it's become popular again. I prefer, sometimes I'll do a lollipop, but not as often. What I tend to do is, I'll just draw it over here, is here's a circle, here's a breast, and then what I do is an anchor incision, or it's also sometimes called an inverted T incision, where it's like this, it's like the lollipop, but it also has an extension under here. And in my opinion, it doesn't really make a difference if you have this incision compared to the lollipop, because this incision that's under the breast is hidden. You don't see it. And people are always worried about this vertical incision, and they're worried about the scar, and I understand, because it's a scar that's coming down the breast. And patients, because over decades we're accustomed to have incisions around the areola, people don't mind having an incision around the areola, but they really kind of get uncomfortable when you start talking about this incision. But roll the film. I'll show you what a scar looks like. I can't remember how many months she is, but I'll show you what the vertical scar looks like. And this scar actually heals the best. If you consider this to be one incision, that's the second one, that's the third one. This one heals the best. And so this is a real patient. I saw her 2 or 3 weeks ago. And that's her vertical incision. And, okay, slow-mo. Ooh, fancy. So obviously we have to blur the nipple and the areola or we'll get banned. But you can see the scar looks, all right, that's pretty good. So you can see the scar looks very nice. And that's typically how patients heal, with that scar. And the advantage of doing that scar there, of making that vertical scar, allows me to cone and shape the breast better. This scar that just goes around the areola tends to flatten the breast. Sometimes for patients that have a tuberous breast or they have a very poofy nipple, areola, then that little incision that goes around there can help us because it will flatten, and we want it to be a little flattened because they're a little bit too poofy. But for the most part, this is going to, if you have quite a bit of droop, I prefer to use this because then we can get a really nice shape to the breast. Now, your question was about an implant and relating to a breast reduction. So there is this concept out there that you can have a breast reduction, we can make your breast smaller, and then we can put an implant in, and now you have fullness up here and everything's hunky-dory and people are happy. In reality, it doesn't really work that way, because patients that need a breast reduction, they typically have a very wide breast. And so if their breast is naturally this wide, or sometimes it's quite a bit bigger, if their breast is this big, so let's imagine this is their breast here, their breast is this big, and they want an implant because they want the fullness and they like the look of an implant. If we put this implant in somebody at the time of a breast reduction, their breast will the implant will just drop because it's too wide. So patients want to have fullness up here, and they want that roundness from the implant. The problem is the implant stays there for about 30 seconds, and then when the patient moves and gets up, the gravity takes over and the implant just goes doop. And over time, that implant drops. And it actually worsens the look of the upper breast, because as that implant goes down, it makes the nipple kind of look like, or makes the nipple move up. And so instead of having fullness in the upper part, they end up getting more fullness in the bottom, and they end up having a nipple that looks up and they have more hollowing here. So I have a whole nother talk and everything else, and there's a video on YouTube. Can you post a link? Are you able to do that? There's a good video explaining why I don't suggest using implants in patients that have a wide breast for breast reduction. People think that the implant is going to keep the breast up, and that is completely wrong. This adds weight to the breast, and this requires your tissue to hold the implant. That's why when we talked about the preserve technique and we try to preserve more ligaments, you get more strength to hold the implant. But if you put this in a breast reduction candidate, the wide breast, this is not going to hold your breast up. This will not give you more fullness in the upper part of the breast. It will do the opposite, and it will give you not a very good looking breast. And check that other video out. It will kind of show that. Okay, so let's see. Let me go through a few more questions. Hello. Yeah, somebody asked me, which placement would you say yields better or more intentional results? So it's variable from patient to patient. So that's why we meet, and that's why we talk about these things and go through and kind of pick the best location, and then I explain why I think it's a better location. So there really isn't just one best location for an implant. It really depends on the patient. Okay. And Xenia says, I've had my implants since 2001, saline. Really now, I can't even remember the last time I put saline implants in. We really don't use saline anymore. I had no issues. They seem fine, but I would like to change them out. My breasts have settled and they have drooped and feel supernatural, and I want to look full. So, yeah, that's what we call an implant exchange. And when we do an implant exchange, we'll remove the implant, and we'll put, depending on if patients want to be bigger or smaller, we'll put it, or the same size. I can measure the implant in the operating room, and then we can decide what size implant to use, whether they want to be bigger, smaller, or the same. And then if they've had droop, then we'll also do a lift. And then the other thing that we do, it's called a capsulorrhaphy. So let me see if I can spell that. That's a can you see that?
No.
See?
Yeah, that's good.
Capsulorrhaphy. I think that's how you spell it. So we'll do what's called a capsulorrhaphy. Well, what is capsulorrhaphy? It's just we're using the capsule and we're reshaping the breast. And so if you've had implants for a long period of time, you're going to have, and again, it also depends on the shape of your chest wall, how big the implant is, how good a quality tissue you have, how good the ligaments are that are attaching. Depends on a lot of these factors. But in general, patients will need what's called a capsulorrhaphy, and that is a tightening of the capsule. And there's different ways of doing it, but in general, if this is your pocket, let's say your pocket is kind of stretched out over time, and saline implants are a little bit harder on the tissue and tend to bottom out a little bit faster and tend to stretch the pocket a little bit. So let's say this is you've had implants for 10 years, and here's your pocket, but your implant is really only more like, it's not nicely tight to the pocket, which we like that hand and glove fit. Then what we'll do is we'll do what's called a capsulorrhaphy, and I'll go through and I'll actually place stitches in here and tighten the pocket. And that will give you a more cleavage, that will give you a fresher look, that will give you a fuller look, it'll give you a younger look, it'll give you a look as if your implants are newer, which when we do an implant exchange, they are. Okay, Love Jen says, hope your day is well. Thoughts on Motiva implants? Do you use it? Yes, I do. And if so, what do you like about it versus the others, such as Mentor? So I don't use Mentor implants and I don't use Allergan implants. That's just my own personal preference. I prefer Sientra, which I think is an excellent implant, or I do use Motiva, which I also think is an excellent implant. So I use both of them, and depending on the patient, that can sometimes enter into it. patient wants. I would say typically right now, patients are interested in the Motiva implant because it's a newer implant and there is newer technology. So I use either. I like both of them. If I had a preference, I probably would be leaning a little bit to Motiva at this point. But I don't use the Mentor or the Allergan implants. Okay. Let's say find some example. I don't know. Let's see. Yeah, so Xenia said she's lost some projection, and really that's what's happened. If your pocket has become a little bit stretched, then the implant will settle a little bit more, and it's not as tight a fit, and so you won't see as much projection, and that's where the benefit of the capsulorrhaphy comes in. Let's see. Oh, somebody, Teresa says, she had saline implants, 2006, under muscle, getting Motiva replacement in a month, getting deflation at pre-op appointment next Monday to decide size, leaning toward going under the muscle again with mesh, lift not needed. So there's a lot to come up there. And one of the things is if you do have saline implants and you want to get them changed, or you're looking at getting them changed, then one of the really nice things is if I say, well, do you want to be bigger? Do you want to be smaller? And someone's like, I'm kind of, there's not totally sure. One of the things I'd love to do is do what we call a preoperative rupture of the implant. And so I can just through the skin, just go through with a needle attached to a syringe, and then I attach it to suction, and I can go and I can break the implant and remove the saline that's in there, and then the patient will deflate. It really does two things. It's not, in my opinion, it's not just for determining size. It's determining it's actually beneficial, particularly if we're going to do a lift. It's nice to give the breast 2 or 3 weeks for it to then contract a little bit, and I think it can make the results of the lift better and safer too. So I think preoperative deflation is really good. I do that all the time. And then Teresa brought up mesh. So I use mesh quite frequently as well. There's different types of mesh. There's a synthetic mesh, and there's a mesh that comes from a pig skin called stratus. Don't freak out. Yes, pig skin. We call it porcine. So you're not going to think you're going to start snorting after the operation. It's a really good material, and I use it for a couple of reasons. I use it to help support the implant in patients with weaker tissue, and I also use it for capsular contracture, which I keep saying we're going to talk about, and we'll get there. Let's see. What's the best position after a lumpectomy? I don't think a lumpectomy would factor into it. You could have your implant in any one of those locations. Let's see. Now I've got some other questions that are not related to breast, and I'm just going to ignore those. I'm not ignoring you, and you can comment or something on another video, and I'll be happy to answer it, but I want to stay on the breast. Do you have breast reduction outcome pictures on the website? Yes, we do, or they're on RealSelf or my social media. Breast reduction is really a wonderful operation because people will say, oh, I want a breast reduction with a lift. Well, a lift comes with a breast reduction. We're never going to reduce the breast and then leave them in the same position. So automatically when you have a breast reduction, it also means a lift. But it's a tremendous operation for women that, and you'd be really shocked, I think, to see some of these patients that have just massive breasts, and I don't even know how they do it. They get neck pain, back pain, shoulder grooving from years of wearing their bra to hold their breasts up. limits them in clothes they can wear, limits in activity, they can feel self-conscious. There's a gazillion reasons to do a breast reduction, and it's a really happy group of patients because we can make the breasts smaller, lift them, give the breasts a better shape, and then we use some of that tissue to be able to do, people call it an auto-augmentation, but it's kind of a restructuring of the breast tissue to give a nice, full, pretty breast. So breast reduction is a great operation, but don't you dare combine it with an implant or you will regret that, and you will hear my wrath if you come in to see me. When am I planning to come to Kenya? I've been to Kenya. I love it. I would love to go back there, but I don't have any immediate plans to do so. Let's see. Lauren is asking, I asked a few weeks ago about the implant on a larger breast, and you recommended the wide breast video above. Can you explain how a larger breast can stay upright with just a lift? Well, a breast will not, an implant will not lift the breast. If you put an implant in and didn't do a lift in someone that needs a lift, then you would end up with a very peculiar looking breast, because it looks like I got Christmas colors going on here. So what you'll do, what will happen, let's just say you want a breast reduction, you need a breast lift, but you don't want the scar, so you just want the implant, because the thinking is, oh, I'll just use an implant and that'll kind of lift my breast. Well, implants don't lift the breast at all. So what that would look like, let's say you had some droop to your breast here, and now we put an implant in, your breast is going to stay exactly the same, and the implant will go, that's Halloween, the implant will go in here and it'll be hanging out here, and your breast will still be falling off the implant, and it would look terrible. So we don't do that. If you need a lift and you want to have larger breasts, then you do a lift with an implant, and you have to do the lift. If you just put the implant in, it would look terrible. So if you need a lift, well, I always say if you need a lift, you need a lift. Okay, Love Jen's got a #1 crown. I don't really know what that means, but good for you. Okay.
#1 viewer on the live.
Huh?
#1 viewer on the live.
#1 viewer.
Yeah.
Love Jen's really interested. Okay. I asked about the J breast lift before, and you answered, but could you tell me who would qualify for that specific lift? Yes, I will. I can tell you exactly. So the J lift is kind of a variation of the lollipop. And so I've done it. I did that when it was very popular, and it was popular for us as surgeons to do the J lift, and it was really a couple of surgeons and one surgeon in Canada. I'm Canadian, and she went to the same medical school I did, and yeah, I'm in medical school still. Now, what that I did, and I had a lot of respect for her, as did a lot of other surgeons in the community. She's written a textbook, super intelligent person, excellent surgeon, really excellent educator. And one of the things that sort of she developed and along with Madame Lejour is this kind of concept of, instead of having the vertical incision with this underneath, it was to prevent this incision. And so what would happen is, instead of that pattern, then it became a J or an L, depending on which side of the breast you were on. Then the incision would come down, and instead of making this incision under here, we kind of run it out this way. And if it was on the other breast, then it would go like that and would run out that way. So I guess people like J more than L because everyone calls it a J lift, but it depends on which side of the breast you're on. But it goes like this and goes like that. I did that. There's problems with it, and the main problem that I learned when I did breast reconstruction, and this is going to come as maybe a surprise to you, but the most important part, at least in my mind, of doing any breast surgery at all, lift, reduction, removing implants, replacing them, anything, the most important part is this actually IMF, this incision, this breast, this fold under your breast. And the more control you have of the IMF, the better job you do of maintaining the IMF. In my opinion, the better result your breast surgery is, no matter what operation you're having. So the J-lift doesn't allow as good a control of that location, because what happens is with the J-lift, the implant or the patient's tissue really determine what the final result is in a few years. Whereas when I can make that T incision like here, then I control this. And what I'm controlling is I'm actually controlling this length here. And I can set that. Whereas when you do the J-lift, it kind of leaves it up to the implant to decide how long this will be. And if the implant descends and stretches the tissue out, you can get bottoming out. So I don't use the J-lift. When I first started doing it, and I did it for, I don't know, probably 3 or 4 years, I was having problems with patients bottoming out and coming back and not being happy. And you don't want patients coming back not happy. So I went to an Atlanta breast meeting. It was a very good meeting, and it's held every year in Atlanta. And I asked one of the speakers there after they had given their lecture. I went up and I said, I'm really having troubles. I'm having some bottoming out with the J-lift. And he said to me, yeah, don't do that. And he didn't really give me any other advice other than that, because there was a long group of people waiting to talk to him, and he was trying to, I think, get lunch. So he's like, yeah, don't do that. You need to make a T. And I didn't really understand exactly what he had told me, but I knew that I respected him, and so I'm like, okay. And so I went back to doing the T, and then I started to realize, now I understand why he doesn't like the J-lift, because we lose control of what that length. If you look at the breast from a side, it's this length here that we can control when we do that T. So that's, I hope, Love Jen, Queen number 1. I hope that answers your question, but that's why I don't like to do the J-lift. And it also leaves some bunched up skin, and you'd have to wait for that skin to kind of shrink, and patients would be like, what is this? I'm like, don't worry, it'll get better. And it did get better from a scarring point of view, but it didn't look good long term. Okay, I'm gonna do 2 more questions, and then let me get back to it. Let's see. Okay, Love Jen, you said you've watched about 80% of my videos. That would take a very long time. But thank you. You're very informative and straight to the point. People always say, they may not say nice things, but they always say I'm honest, and I am honest. I'm too old not to be honest about this. And I don't try to sell patients or push them into doing something, because I never want to be that person. But I think it's just absolutely imperative that you're clear as to what surgery you're getting, why you're getting it, why we're doing it this way, all that type of things. What challenges, if any, does having dense breast tissue have on getting a breast lift with an implant? It really doesn't affect things. It affects me during the surgery, but it doesn't really affect your end result. So I wouldn't say that factors into it at all, whether you have dense breast tissue or not. Okay, I can't remember where I am. I'm gonna ask one more. The IMF incision makes sense. Maybe patients are trying to avoid scar. Yes, no, I get why I totally get why somebody says, well, I would rather have that incision than that incision. I totally understand it. But I think what patients may not realize is that this incision here is concealed in the breast, so it's not even visualized. That video that we showed earlier, that patient scarring, in order to see that underlying, you don't have to show it, it's fine, but in order to see that underlying scar, the patient would have to lift their breast to see it. So to me, it doesn't make sense if we're gonna, I get it that it's a longer scar, but if it's not visible and doesn't really impact things, then if we're gonna get a better result by using it, then then that makes sense to use it. There are times, I should say this, there are times when I do the lollipop. Those are patients with a certain breast shape and they don't have a lot of droop, but they have some droop. They're going to be better served by having a lift so I can make the vertical scar to cone it. But they don't have so much droop that I need to remove any skin or do anything in that under part, and those patients will have a lollipop. Or they'll have a lollipop with a very small T. The length of this T here, the length of this incision, depends on how much droop you have and how much extra skin you have. Because if you imagine when we're doing a lift, we are using the implant. I'm shaping the breast over the implant. Now, technically when I'm doing it, I'm shaping it over the sizer because I want to put the implant in at the last minute so that it just comes out of the box, goes straight in, and is not contaminated. So, but really what I'm doing when I'm doing a lift is I'm shaping it over the implant itself. And if I need to remove some skin down in this lower part to allow it to fit the implant better, I think that's how you get a better look. So, okay. Yeah, Platiza says, oh, you're number one, Platiza. Do we have any yay music? I've had breast reconstruction and you really can't ever see it, the IMF scar. Yeah, for people that have had the IMF scar, they don't really care about it. They never talk about it. They never ask about it. They never question it. It doesn't really come up. It's just something that's there that they don't see. It doesn't bother them. It's kind of like the elbow, you know. You don't really look at your elbow very much, so you got something going on in your elbow, it doesn't really bother you. But for patients that have had surgery and have the IMF scar, they understand, yeah, this doesn't really affect anything. But preoperatively, patients are like, whoa, I want the lollipop. I don't want to have an extra scar under there. But it really gives you a better result. So that's why I think it's good to use. And I know that it doesn't create a long-term problem where patients are bothered by it. So, but at the beginning, before patients have surgery, scarring is always very a big discussion, and it also comes up when you're talking about tummy tuck scars. Before tummy tucks, patients are worried about having that scar, which of course I understand, but over time it really becomes a non-issue. It's usually patients worry about it a lot before surgery, but after a couple of years, once that scar has matured and they've done a good job of scar care, it really kind of becomes a non-issue, and they like their abdomen and their belly button. So, okay, where am I going to go from here? Let's talk about, there's too many things to talk about everything, so I'm going to do, let's see, I'm going to be better with time tonight because I always go on forever. Obviously, I talk a lot. I'm an over-explainer. So, let me look at a couple of things. Let me just check off some things talked about. Talked about size and location, type, brand, preserve. Okay, there's complication we haven't talked about. Recovery we haven't talked about. Cleavage, tuberous breast, lifting we sort of talked about a little bit. Implant removal, fat grafting is something we've talked about. Okay, so let's do this. Let's talk about some complications. Let's talk about recovery, and let's talk about fat grafting to the breast. And then I'll take a few more questions after that, and then we'll call it an evening. Okay, let's talk about complications. So what complications can you have after having let's say a breast implant with a breast augmentation or a lift with an implant? Here are the complications. So I'll write them right over here. I won't write them in red. That looks too sort of sinister. Let's use this periwinkle. Periwinkle was my favorite color during when I was a kid, and there were the Crayola box of 128. Remember when there was a box of 64 crayons, and then my mom came home with a box of 128, and we used to color together, and both of us loved this new one because it was periwinkle. Anyhow, it's good time management. All right, what am I talking about here? Okay, complications. So complications. It's funny how you remember these things as a kid. So complications after having, let's just say in general, breast surgery or when you're using implants. So with all surgery, you can have a risk of infection. You can have a risk of bleeding, which we call a hematoma, but that's just blood. It's like a big bruise. You can have something called capsular contracture. You can have implant malposition. You can have a double bubble. You can have symastia. Okay, let's just go through these one by one. So infection, pretty low rate of infection. There's a whole bunch of things that we do before surgery, in the operating room, to prevent infection. This is going to be, I'm super, super excited because I'm going to be talking to Dr. Dustin Long from University of Washington about infection because he's got unbelievable research, and I'm going to have him on a podcast. But infection, everyone thinks infection is because there's some break in sterile technique, there's some problem, there's some mistake made. Actually, infections comes from the patient's own skin and own bacterial flora. But that's a very long discussion. I'm going to have a podcast. That I would really encourage you to watch because it's absolutely it's so interesting, at least to me anyway. So infection, it's possible, but it's, I would say, less than 1%. It's not common to have somebody with an infected implant, but it can happen. It's a bit of a disaster when it happens because we have to remove the implant, wash everything out, and leave the implant out. So you can have one boob and one flat boob. And that can be very difficult. And I've never met anyone who's had infection. I've had infected implants. Every surgeon who does enough cases will have it. I've never met anyone where I say, well, I'm going to take your implant out, leave it out for 3 months, and then put it back in. I've never had anybody not cry when I've told them that, which obviously you would, thinking, well, how am I going to cope? People usually do cope pretty well. But it's something that doesn't happen very often. Hematoma, that's also probably about 1%. Hematoma is when you have bleeding inside the pocket, and we have to go back in. We'll open up the incision, we'll remove the implant. I use an acid and I do a few other things, but we basically evacuate the hematoma, remove the hematoma, wash everything out. Usually you don't find anything that's bleeding, it's already stopped. But we look around. If anything's bleeding, we stop it. But again, it's not common. Capsular contracture, this is a more common complication. It's something important to understand. When patients ask me, what's the one thing I need to know? Actually, people never ask me that. I just made that up. But if I was telling somebody on an airplane and they're like, well, what's the worst thing that can happen if I have an implant? Well, capsular contracture is a problem, and the percentage is variable. There's some studies that show that it's very low. When I was training, we used to tell patients it was 10% chance that you'd have a capsular contracture. Now I tell patients it's about 3%, and that number kind of fluctuates as to what surgeons will tell you. But the number I use is 3%. What is a capsular contracture? Capsular contracture is if this is the implant, then your body will recognize that this is not your tissue, that's not any tissue, and what your body will do is it'll put a capsule around it. Every single patient that has an implant right now has a capsule around their implant. That's normal. That happens to 100% of patients. Most of the time, 97% of the time, doesn't pose any problems. 3% of the time, patients, that capsule itself can become firm it can distort the implant, it can then contract and move the implant up the chest, so you get that kind of dissociation between here's my implant and here's my breast, so it can start to look a little odd. And the treatment for that is we will remove the implant, we remove the capsule, we'll wash everything out, I use that acid, hypochlorous acid, and then we'll put a new implant in. We change the pocket, some other details, but put a new implant in and it just resets the clock. If you've had one capsular contracture, you are higher likelihood of developing a second capsular contracture. If you develop a second capsular contracture, then that's where we use the pigskin, the stratus, because our studies have shown us that if we use stratus, then the chance of you developing another capsular contracture is almost zero. And so we usually don't use it in a first-time person that gets a capsule, but if somebody develops a capsular contracture the second time, then we usually do that because their chance of developing a third capsule is very high. And so it wouldn't make sense just to do the same thing you did the first time, and that's where we use the stratus. Implant malposition, we can see this is something that we see, I would say, I see it in Miami more than I've seen it when I practice in North Carolina. And that's really by over dissecting the pocket, using an implant that's not the correct size for the patient. And the implant can kind of have that dissociation again, where it's not a hand and glove fit and the implant is in a different location than it needs to be. That we usually remove the implant and then correct the pocket. It really just sort of technical things we have to do inside. Double bubble, I see this more often than I think I would expect to see it. But the double bubble is where you have your breast and then there's another little bubble here. And that's the double bubble. And what that really is that fold that I was talking about here, where I put the stitches in to anchor it. You can lose that fold, and then the implant will come down, and it'll kind of give you that two boob look where you have the other part. There's patients that preoperatively we can see, and in fact, I have a patient I saw earlier today who would be a setup for a double bubble. So I think that's why I see it, is that people don't necessarily recognize it beforehand. They think this is a regular augmentation. They go in to put the implant in, lo and behold, they develop a double bubble. It's not common, but if you have it, it's really not, patients don't like it. And then we have to go in and we have to correct that fold and reset that fold. Symastia is where you have your breasts basically become one, and that again is a technical issue where that pocket was over dissected in towards the midline. So if here are your breasts, and this is the midline, and the dissection was carried out for patients trying to get more cleavage, or an implant that was too big is used, and so that pocket where it really should be created to here, the pocket was created here and the pocket was created here, and now the implants start to move to the middle, and they can get very close to touching, so you kind of get this sort of look to your breast. We call it bread loafing or symastia. It's not very common, but it can happen, and it's a little bit more challenging to repair, but we can do it. But these things, the implant malposition, double bubble, symastia, typically not very common complications. Infection, not very common. Hematoma, not very common. Capsular contracture is the most common one. That's the one I make sure everyone understands that before surgery, that you can develop a capsular contracture and your breast can become hard. It's not something that happens frequently to patients, but there's enough breast augmentations that are done in the country that we do see them more commonly than any of the other complications. Okay, let's talk about recovery. Recovery is fairly easy after breast augmentation compared to a lot of the other things we do. It's not a difficult recovery. I think one of the challenging things is to actually explain to patients that after surgery you can move your arms. And so the kind of usual way, if we don't say anything, patients will come back and they'll be like, I had breast surgery and I cannot move, and they don't do that. And we don't want that. It's safe to move your arms after having a breast augmentation with an implant, and we like patients to do that. Usually patients will have, if it's under the muscle, it's about 48 hours of pressure. It's not really like a sharp, terrible pain. It's more pressure as that muscle gets accommodated to having an implant underneath there. But after those 48 hours, that usually dissipates. Patients can return to their usual daily activities, so showering, dressing, eating, going to work, all those types of things, usually in about 3 or 4 days. It's not a long recovery. I like patients to wait 3 weeks before they start doing some exercise, and then at 6 weeks they can do full exercise. But this is not something with a long recovery to it. Okay, let's talk about fat grafting. This would be the topic for a whole nother live, but let me explain to you what it is and when would we use fat grafting. What's the indication for it? Why would we suggest it? And so, fat grafting is, if you heard of a BBL, it's the same thing. We, as plastic surgeons, I don't operate on the face, but I do have a super nice person. I love this man. Coming to, he practices in New York, but he's going to be spending some time in Miami as well. And he's going to be focusing, Dr. Suzman. He's just a gentleman and a super well-trained surgeon, Ivy League trained, and technically really good surgeon with great results. But he'll use fat and put it in the face. So there's a lot of different places you can put fat in the face. Use it in the lips. You can use it in the cheeks. You can use it really throughout the face to what they call volumize the face. Because as you age, you can lose fat. And so they'll help to restore and give a more youthful face by using fat. That's fat grafting. Fat grafting is just like a skin graft. If you take it from, if you have a burn on your arm, take a little bit of skin from your leg, we can put it on your arm. That's a skin graft. It's your own skin. It'll take a new blood supply. It'll heal. That's a skin graft. We can do the same thing with fat. We can take fat from one part of your body, transfer it to another part of the body. So it's most commonly done in the face, and then you'll have heard about it in a BBL, Brazilian butt lift, where we're doing liposuction and we transfer that fat to the butt. Well, we can also transfer fat to the breast, and I've been transferring fat to the breast longer than I've been transferring fat to the butt because it's been around for a long time, and I used to use it a lot during reconstruction. And the reason why I use it during reconstruction, so these are patients with breast cancer, they've had a mastectomy, and they could have reconstruction with an implant. The problem is, the way we used to explain it is, your breast is like, imagine a fried egg. So you kind of see the yolk as the main part of your breast, but there's also the white part of the egg that's there as well. But when they do a mastectomy, they take the whole fried egg out, and when we do reconstruction, we're kind of just putting the yolk back. And so what we can do is we can use fat that we get through liposuction, and we can take that fat and we prepare it, and there's a lot of different steps, and we can take that fat and we can use it to replace the egg white, if you imagine it that way. So the implant will kind of be the yolk of the reconstruction, and then we can blend that into the rest of the chest to make it look more natural, so it's not just here's your implant, and because the patient's lost their whole breast, so then we can put in some fat to blend the implant and into the chest so it looks a little bit better, and it can help with radiation, and it's very helpful. That's for reconstruction. We use it in the cosmetic field. I don't do reconstruction anymore. I only do cosmetic work. We can use it in cosmetic work, and we can use it in the breast. Okay, well, when would be a good indication? Does everyone who has a breast augmentation need fat grafting? No, because these implants, the newer technology, they're nice and soft, and with the patient's natural tissue, you can get a really pretty result. There are some patients who can have a breast augmentation, and just because of the shape of their breasts or the shape of their chest or the amount of fat that they have, they'll benefit from having a smoother, just like the breast reconstruction patient, they can have a smoother result if around the implant I can also put some fat, and that can kind of soften it. So sometimes I'll use fat grafting to the breast with a straight breast augmentation. That's not the most common time I use breast fat grafting. You can use fat grafting also without an implant. So if somebody comes in and they want a breast implant, they want a breast augmentation, they want their breast to be larger, they want more cleavage, more fullness, and they don't want an implant, then we can use fat to do what's called a primary augmentation. So if you've never had any breast surgery and we're going to put an implant in, we call that a primary breast augmentation. We can do a primary breast augmentation with just using fat. Now, the important thing to understand is that if we look at this implant is 400 cc's. I can't put 400 cc's of fat into the breast. We can't put as much fat into the breast as you can with an implant. So if you really want a larger breast, a bigger change, and more fullness, then you're better off with an implant. If you want to avoid an implant, then you can use fat to do the primary breast augmentation, and you can have a nice breast and you can have a really nice result, but we can't give you as much of a size change. So if someone comes in and says, well, I don't want an implant, I want my breasts larger, I don't really want them huge, then I'm like, ding, 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 you're a perfect candidate for fat grafting because you get the benefits of the lipo, which are really not to be understated, and then we can use that fat to augment what you have. This is not somebody who's completely flat. This is somebody who has some breast tissue and they're just a little bit kind of, that sort of gap you can get here at the top of your breast with a little bit hollowed. So we can put fat in there. So without adding an implant, we can get a rounder shape and a fuller shape and a prettier shape, and we can also develop the cleavage much more. So I can use it to do just a straight augmentation without an implant, or I can use it with an implant. That's not as common, but I can use it just to enlarge the breast, but just using fat, but it's a smaller volume augmentation. Occasionally, if patients are really like, I really don't want an implant, they may undergo a second round of fat grafting to the breast if they want more volume. The other time I'll use fat grafting to the breast is in patients that have had a lift. So if we just, even with or without an implant, there's things that we do during the surgery to try to get the most volume, but we can get more cleavage and more fullness by adding some fat in there when we do the lift. I also do it, ironically, with a breast reduction. So patients will go in, we can reduce their breast, and we can reduce their breast. This is 400 cc's. We can reduce their breast by 400 cc's. We can reduce their breast by 800 cc's. We can reduce their breast by 1200 cc's if they have really big breasts. So we can do that, but we're always chasing that look where we get more upper pole fullness and more cleavage, and fat can also help us to get that. So I use fat essentially for not in every operation, but not in every patient who has an operation, but it can be used with every breast operation that I do. And so I'll bring that up selectively to patients who I think would be a candidate and would benefit from it. I'll say, if we're going to do some lipo, it would be a good idea we can use some of that fat in your breast to get some more fullness in the upper pole and get a little bit more cleavage. So breast fat grafting is really good. It's and like I said, I've been doing it for a very long time, and it has really nice results. If you're expecting to come in completely flat and look like you've had an implant with breast fat grafting, it won't do that because we can't put the volume in. But it definitely has a really nice role. There's another thing too that we don't really talk about too much, is that there's different types of preparation of the fat. So we can use what we call nanofat, which is a very, very, very highly sort of processed fat. And we can use that, and I always add a little bit of nanofat to when I'm doing a fat grafting to the breast. The nanofat doesn't have any structural support. It's not strong. It's really been broken up into sort of its little constituent parts. But that fat is not good for giving you cleavage and fullness, but that fat is really good at treating the tissue. And fat is really good, particularly nanofat, for treating the skin. And it can really help soften the breast, can fill in some little sort of irregularities, and it overall helps the quality of the skin. So I always put a little bit of nanofat in when I do breast fat grafting as well. Okay, I think I went through those things, and we've got about 5 minutes left. I'll take a few questions and then wrap it up. Does that sound good to you, gentlemen? Okay. All right, let me lift up this brick and let's take a look. You guys have a terrible boss. You're working with iPads from the 2000s. Okay. Oh, excellent question, Tanola. I hope you're still here watching. How much tissue is removed with a lift versus a reduction? Excellent question. So, it's the same operation when we do a lift or we do a breast reduction. There's different techniques, but in general, just think of it as the same. We're going to do, so let's say somebody comes in, they have droop, they like their size. When they put their bra on, they're like, yeah, I like my size. I'm not looking to be smaller. I'm not looking to be bigger. I just don't like the droop. I just want you to lift my breast. No problem. That's a mastopexy. That's just a straight breast lift. Will your breast be a little bit smaller after that? Yes. Will it look like it's smaller? No. It'll look actually like it's a little bit bigger because it's fuller. All your breast tissue is in a smaller package. But in order to get it into a smaller package, we have to remove a little bit of tissue. And just by the way we do the operation, a little bit of tissue comes out, but not very much. So for a straight breast lift, we're not, the patient doesn't want to be smaller. We're not trying to make them smaller. We have to remove a little bit of tissue to put it in a smaller package, but their breast will actually look a little bit bigger. So with a breast lift, you really maintain your same size. With a breast reduction, we're also doing a lift, but instead of preserving the tissue that's there, we're going to be removing some tissue because the patient wants to be smaller. So when we do a lift, you don't have to, you can basically be the same size. If you do a breast reduction, we're doing a lift, but you want to be smaller, so your breast will be smaller. If we do the same operation and we add an implant, then the breast will be larger. It's the same operation whether we're making the breast smaller, keeping it the same size, or making it bigger. If we're making it bigger, we're adding an implant, we're adding fat. If we're just doing a lift, the breast stays the same size. If we're doing a breast reduction, we do a lift, but the breast gets smaller. So, okay, that was a good question. Sandra, the implants that I do not use, I don't use Allergan and I don't use Mentor. And I don't want you to take it that they're terrible implants. It's just over the years, that's kind of how things have shaken out for me, where I like Motiva and Sientra. Okay, Simone is asking, would you suggest fat grafting to the upper breast after reduction and lift has already been done? And what is recovery time after that is done? So, yeah, that's a good question too. So somebody can have, let's say you've had a breast reduction, and with a breast reduction, over time, you'll have some droop and you can develop some hollowness here. Now, if you don't have a lot of droop and you like the shape of your breast, then we can simply go in and do lipo and add fat into the upper part of the breast and cleavage, and that can help refresh your breast and give you a better look to your breast. The recovery from that is not bad at all. Fat grafting to the breast, if it was just fat grafting to the breast, the recovery is nothing. It's very easy. The recovery is from the lipo. So some surgeons will just take a little bit of fat from whatever area, maybe a little bit in the flank or a little bit in the inner thigh or sometimes around the knee, and take a little bit of fat and put that in the breast. Usually when I do breast fat grafting, I go for the whole enchilada, and I'm doing lipo 360, and then I use that fat. So then the recovery is based on really the liposuction and not based on where the fat was placed in the breast. Okay, one more question. All right, let's take a look. I love Jen is still staying strong. Good for you. No wonder you got that crown. Ain't no one taking that crown. No, Sandra's taking the crown. Okay. All right, let's end up with this one. Latoya Thomas Mitterhoff. How long can you keep the implants, and when do you have to replace them? So, you really don't. If the rule of thumb is, if you don't have any problem with your implants, we tend not to replace them. So if you've had your implant for 12 years and you're happy with the size, you're happy with the shape, you really don't have any droop, your implants have not bottomed out, you're happy, then you don't need to have anything done to your breast. And I have saved patients thousands and thousands of dollars. I hope my wife's not watching this. I've saved my patients thousands and thousands of dollars by them coming in and saying, well, I've got my implants for 10 years, I need to have them changed out. And I said, are you happy with the breast? Oh, I love my breasts. Breasts are the best thing I ever did. Oh, okay. Well, why do you want to have them changed out? Well, because I had them put in 12 years ago, or 11 years ago, 10 years ago, 15 years ago. Sometimes patients will feel really guilty, and they'll be like, I had my implants placed 15 years ago, and I just haven't got around to having them replaced. And I know you have to have them replaced every 10 years. And then I say, same questions, you're happy, I look at her breasts, everything's fine, everything feels fine. They don't need to have them done. And they don't need to just change out an implant for the sake of changing out an implant. If you have the capsular contracture, if your pockets have widened, if your breasts are going to the side, if you're not happy with your breasts, then that's an indication for surgery. But simply the fact that the implant has been there for 10 years doesn't mean you have to have your implant changed out. So I'll leave you with that. I appreciate everyone watching. I appreciate the questions. Great questions. I think what people sometimes don't realize, I learn as much from you as you learn from me. This is really a two-way street. How do you think I learned all this stuff? From you. I've learned all this stuff. Do you think I knew how long it took a patient to recover from a breast augmentation before I started practice? Not really. I knew how to do the operation. But I learned everything from recovery from patients, and patients have given me tips. Oh, I did this was better, I did that was. So I've learned a ton of things, and your questions and your comments are really helpful for kind of moving all of this along, because it stimulates me to think and it teaches me. So I appreciate questions and I appreciate comments, and you can ask me. I go through my YouTube comments or questions, and I answer them. If somebody's like, oh, I'd like to something or other on a after, then I just delete that comment because it's rude and there's ain't nobody got time for that. But if you have good comments or whatever, and I think I'm skilled to answer them, it's within what I can answer, then I'll answer them, and I'm happy to do that. And it also helps me, because then I can understand, oh, well, I've made 10 million videos, but I've got 3 patients asking me this question. Clearly I did not explain it well, so that will help me make a video. And so it's really useful, and I love the dialogue, and I would encourage you to follow me on Reddit. it's a nice environment. It's funny how these social media platforms are a little bit different, and some are better for one thing, some are better for another. But Reddit is really nice because it's small, but we have our own little community there, and I can get into a little bit more dialogue with patients. So if you haven't used Reddit before, it's pretty cool. There's a lot of good posters there or Redditors that are there. And I encourage you to join our community. It's the same name, Dr. William Miami, and join that. And then if you have questions, we can talk about it there as well. I can't give medical advice, so you can't say, well, if I have this or this. What I can share with you is experience that I've had with other patients and talk about what they've done or what my patients do. I can't answer a question directly, obviously, without seeing you. I can't be your doctor on Reddit. But I can usually answer questions that are at least close enough that may be of help for you. So thank you again. Thank you very much. I appreciate it. I think I have one more OG Roadshow. I got to talk about that. When is that? Saturday, March 21st in Orlando. We are doing the OG Roadshow, which we love it as a group of people. We have fun going there. And so that's going to be in a hotel. There'll be an announcement coming. And then that's going to be a really nice setup because Dr. Suzman, Michael Suzman, if you didn't hear me before, a surgeon from New York, outstanding individual, this person. And he's going to be joining me there. So the format is going to be kind of nice. I'll give a lecture on, say, breast reduction and show the steps to it and before and afters and those things. And then I'll have time for consultations. Dr. Suzman will then talk about rhinoplasty or ears or facelifts, neck lifts, all facial fat. He'll talk about that. Then he'll see some consults, and we'll kind of do that for the whole day. So it's a really nice way to, if you're interested in a topic, to get more information about that topic, because it's a lecture format. It's a presentation where I'm up there with the laser pointer and my talk, and then we can ask questions too. So it's usually a good dialogue. I love doing the OG Roadshows. It's fun. I think this is our 9th maybe OG Roadshow that we're going to be hosting. So if you're in the Orlando area and you got nothing better to do on Saturday, March 21st, look for the announcement because we're going to be doing that again. So good night. Thank you so much. I really appreciate it. And I hope you all have a good rest of the evening. Hey, it's Dr. William. Grab your markers.
Have you ever wondered why?
Light go through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about...
Okay. Yeah, okay, relax.
Welcome to my YouTube channel.